Η ομάδα χρόνιας αποφρακτικής πνευμονοπάθειας φέτος αποφάσισε σε συνεργασία με το ΔΣ να δώσει την ομιλία της ΧΑΠ που συνήθως ακολουθεί το στρογγυλό τραπέζι στην καθηγήτρια Stolz, που είναι προσκεκλημένη ξένη ομιλήτρια, με σκοπό να θέσει ένα θέμα το οποίο είναι πάρα πολύ σημαντικό, γιατί το ακούμε πάρα πολλές φορές σε όλα τα τραπέζια της ΧΑΠ, ότι μειώνονται οι παροξύσεις. Ό,τι και να δείτε παρέμβαση της χρόνιας αποφρακτικής πνευμονοπάθειας μειώνει τις παροξύσεις. Το ερώτημα είναι, αυτή η μείωση των παροξύσεων οδηγεί τελικά στη μείωση των θανάτων από τη χρόνια αποφρακτική πνευμονοπάθεια? Είναι πολύ μεγάλο ερώτημα. Και αυτό θα μας το απαντήσει σήμερα. So, it's my great pleasure to present today Professor Stolz from Switzerland, from Basel. Diana is a distinguished clinician and researcher and currently is chairing the Educational Committee of the European Respiratory Society. And today she's going to address a very important and I think also provocative issue regarding whether the reduction of exacerbation could affect mortality in patients with COPD. So Diana, first of all, welcome to Greece, and we are looking forward to hearing your talk.
Thank you. Thank you very much, Stolz, for the very kind invitation to come here today. I have the privilege to have contact with several people from Greece, both as friends and collaborators. So it's an honor to be here today. Thank you very much. And I would also like to say, I'm not sure what everybody knows, but Professor Lukidis has been elected the e-learning director of the ERS. So I'm very happy that the ERS will be also strengthened by a further Greece person. And I've been asked today to talk about reducing exacerbations of COPD affecting mortality. And this is a very interesting and clinically relevant topic. Those are my conflicts. And I would like to do that by breaking down this topic in three different ones. I would like to talk about the association between exacerbation and mortality, to talk about whether prevention of exacerbation equals prevention of mortality, and to discuss further approach that might be linked to a prolonged survival in COPD. And as you all know, there is a huge heterogeneity in COPD. We have several patients with the same airflow limitation that might have really different clinical presentations. And based on that, we've learned in the last years that lung function is not the most important thing in the evaluation of risk of a patient with COPD. So there is a heterogeneity of COPD, and we have here data from the ECLIPSE study. And as you can see, we have differences in presentations from patients according to the GOLD categories, stage 2, 3, and 4. And as you see here, the proportion of patients showing dyspnea according to the MMRC score, it varies a lot. Also within the same airflow limitation as characterized by the GOLD classification. The same is true for the exercise capacity, the same is true for the quality of life, and the same is also true for the number of exacerbations. So patients with the same airflow limitation as assessed by FEV1 might have a different number of exacerbations, and we do have patients that have no exacerbation at all, but we do have patients that have a lot of exacerbations. And this particular group of patients is at higher risk for a poor prognosis. As you see here, we can have, depending on the health system this patient is treated on, you can see that the prevalence of patients with exacerbation may vary. For example, in Brazil, 61% had a presentation to the emergency room within the last years. We have other countries where this percentage is only 8%, like in Slovakia. So it depends not only on the disease, but also on the health system the patient is being treated upon. And the problem with the exacerbation is that the probability of you having a next exacerbation is higher the more exacerbations you had in the past. So your risk is dependent upon what happened to you in the past. The more exacerbations you had, the more exacerbations you're going to have in the future. And the mortality risk increases with each new exacerbations. There is a 5-fold greater risk of mortality after the 10th exacerbation of COPD, and we know based on studies looking at remodeling in the lung, looking at the extracellular matrix in the lung, that each exacerbation leads to remodeling that decreases lung function. And this disruption in the lung function cycles might not be fully reversible, meaning that with each exacerbation there is a further reduction in lung function that is not fully coming to the level it was before the patient had this exacerbation. Exacerbations are clearly linked to mortality, particularly the ones requiring hospital admission. So it's been reported that 5% of the patients admitted to the hospital with a severe exacerbation will die in the hospital. The mortality remains high during the first 3 months after discharge, and it's considered to be over 50% at 5 years. So at 5 years, the half of the patients that have been hospitalized for a severe exacerbation is dead. And I think this prognosis might be much worse than for several different cancers that we see, like breast cancer, for example. There are identified risks for mortality, which include older age, male sex, prior hospitalization, low body mass index or weight loss, poor quality of life, increase in PCO2, pulmonary hypertension, and other comorbidities. And we also know that if we compare COPD exacerbations with myocardial infarction, mortality of exacerbation is higher than the cardiac mortality, what does not seem to be really fully recognized by the population. If we look what happens over time, there is a clear differentiation between the prognosis, survival in patients with no history of previous exacerbation as compared with the group with 1 or 2 severe exacerbations in the past as compared to the group with more than 3 or more severe exacerbations in the previous years. So you can dichotomize these patients in 3 different groups, and the mortality is very high, meaning that the survival is very low, around only 30% after 5 years in the group with 3 or more exacerbations in previous years. So we're talking about severely sick patients. The exacerbation impact not only quality of life and lung function. Patients have symptoms, as we know. There is an increase in cough, increase in shortness of breath and fatigue, increase in sputum production, increased disability. The half of our patients are confined to bed. If they have a severe exacerbation, they lose muscle mass with every exacerbation, around 3%. They have a decrease of maximal VO2 max. And they have an increase in systemic inflammation. So if we look what happens with patients admitted to the hospital at exacerbation, we see that the minutes they are able to walk per day are massively reduced during the first week, and still 1 month after the exacerbation, still reduced as compared to the stable state and with patients without COPD. It's so impressive, the effect of severe exacerbations for the prognosis of the patients, that if we use the so-called BED score, which comprises the BMI, the severe ACOPD frequency in the past, the dyspnea severity score using the MMRC, and the COPD levels, if they are available, we see that there is no added value of lung function if the patient had a history of 1 severe exacerbation in the past. So if you had the history of 1 severe exacerbation in the past, no matter how your lung function looks like, you have the same risk of death. And this shows how important and how relevant the risk associated with mortality is linked with the history of severe exacerbation. There are several interventions that have been proved to decrease the prevalence of exacerbation in COPD. Risk modifications such as smoke cessation and vaccinations, pulmonary rehabilitation, the self-management intervention programs, pharmacological therapies like bronchodilators, ICS, phosphodiesterase 4 inhibitor, mucolytics, antibiotic prophylaxis, vitamin D and beta blockers in certain patients. So all these things have proved to prevent exacerbations. Some are more effective than others, and some are only effective in certain subgroups of patients, but they all proved effective. But we have to be aware that not all these interventions have proved to decrease mortality. And that's actually my topic today. And although not all of them proved to be effective in decreasing mortality, it is still to assume that by decreasing the prevalence of severe exacerbations, you might be able to decrease mortality. And I will show you the evidence for that. What we also know, if you look over time at the mortality related to COPD, is that it seems like we are doing a good job. So if we look at the mortality associated with COPD or the survival associated with COPD back in '97, we've seen that around half of the patients were alive 3 years after discharge. If we look at the survival of patients in 2004, this number has been improved by over 60%. So we seem to be doing something right. One could also make the point that cardiologists are doing a better job because mortality for cardiovascular diseases are decreasing. But the fact is that the chances of a patient to be alive today after they are discharged from the hospital with severe exacerbations are higher than 20 years ago. So what are the interventions associated with a positive impact on mortality? And I would make the case that those are smoking cessation, the use of long-term oxygen therapy, lung volume reduction surgery in some patients, and non-invasive ventilation. The data to support the recommendation of a smoking cessation program comes from 2005. And in this study, the survival 15 years after entering a smoking cessation program has been examined. And as you see here, patients that were included in the cessation program had a better survival as compared to patients that received usual care. So we know that smoking cessation is not only beneficial for the decrease in FEV1 according to the Fletcher curve, but we also know that taking the patient in a smoking cessation program really prolongs survival. The second therapy that seems to be efficient, also considering that we have new data suggesting that this effect might not be that pronounced as we've seen here in 1981, is long-term oxygen therapy. Consider patients with hypoxemia at rest of PO2 less than 55 milliliters Hg and using oxygen over 16 hours per day, and we see a markedly decrease in mortality in these patients. We also have evidence that lung volume reduction surgery might be effective to reduce mortality in a subgroup of patients. So in patients with a low FEV1 and DLCO and homogeneous emphysema, there was actually a significant or a borderline significant increased mortality with surgical treatment, while in patients with low exercise capacity and emphysema predominant in the upper lobe, there was a significant higher mortality in patients receiving medical treatment, suggesting that low volume, lung volume resection surgery might lead to a lower mortality. What we don't know is whether bronchoscopic interventions that do not require surgery, like coils and valves, could also lead to an improvement in survival. We've heard a lot about this. I didn't understand everything that my further speaker said, but I think she presented a lot of very nice data supporting the use of NIV in patients with stable COPD, and I'll just focus on this study published in 2014 that, in contrast to several others, really achieved a decrease in PCO2 and could really demonstrate a decrease in mortality in patients undergoing non-invasive ventilation. So I think for these interventions, we can really say there is some evidence suggesting a significant effect in mortality. What about rehabilitation? I think here we will have to say that perhaps there is an effect in mortality. This changed a few years ago with a new edition of the Cochrane Library Review. And as you know, based on this work by the East London group, we know that the earlier we intervene with the therapy in patients with symptoms, the shorter this patient will have symptoms as related to the exacerbation. So there came the notion that one could start rehabilitation in hospital for patients with acute exacerbations of COPD. And there is a study showing that the patients that received early, within 48 hours, in hospital rehabilitation for COPD did have difference in the readmission rate at 12 months, but there was also an increased mortality in this group, suggesting that early rehabilitation might be deleterious in patients with acute exacerbations. For rehabilitation start a bit later, after discharge, there is really inconsistent data on readmission and mortality. There is a large effect on the quality of life and exercise capacity, and there is enhanced muscle performance and mobility, but we cannot really say with all the certainty that this has a positive effect on mortality. And those are the new figures from the Cochrane Review. You see on the left-hand side data for readmissions, and on the right-hand side the data for mortality. And as compared to the revision performed in 2011, where there was a clear significant effect for both mortality and readmission, nowadays it seems inconsistent whether rehabilitation can really decrease mortality in COPD. So, what about things that do not officially have an effect in mortality? And unfortunately, I will have to talk about pharmacotherapy here, because there is little or not really strong evidence supporting the fact that bronchodilation, or at least pharmacotherapy as such, could significantly reduce mortality in COPD. If we look about what we know about pharmacotherapy, and I put here results together of several trials, we know that long-acting bronchodilators and ICS improve health status, lung function, and reduce exacerbation. We know that the combination therapy tends to be better than monotherapy, particularly if we look at lung function. That LABA, ICS, and LAMA might influence different types of exacerbation. That taken as a whole, bronchodilations tend to be better than ICS, and that LAMA tend to be better than LABA for patients with COPD. And we have actually learned, based on the several results we had over the last years, that you need to do actually the study and not just rely on the post-hoc analysis results to recommend something in COPD. Despite all these positive effects of pharmacotherapy in COPD, we do not have a proven effect on mortality. And I go on through with you to the data through that. The first study that was a bit sad is the TORCH study, published in 2004, that included almost 6,000 patients that were randomized to the combination therapy LABA-ICS versus LABA versus placebo. And as you see here, the probability to die was lower at the end of the study, but this p-value did not reach statistical significance. So although it looks like there is a bit less mortality, unfortunately this p-value was not significant. This was the case because it has to be adjusted for the interim analysis. So although this is not statistically significant, it's really close, and I think we can all assume there would be at least a small effect on mortality. This would be an absolute reduction of 2.6%. Again here, there is a significant effect in the decrease rate of the moderate and severe exacerbation comparing placebo with the combination therapy. The second story that was also a bit sad was the UPLIFT study. Here, there was a combination or a comparison of LAMA as combined to control, looking at mortality. And again, at the end of the study, there was a difference that was statistically significant. 30 days afterwards, this difference was not present anymore. And this has been defined as the primary endpoint of the study has to be considered technically as a negative one, with no effect in mortality for the whole duration of the study. Again, they're very close, but technically a negative study. I think those things would not happen to cardiologists, but unfortunately in pneumology we have seen this twice now. There are some other things that proved an effect in exacerbation, for example, azithromycin. Here, the American study, we also have an European one published in the Lancet Respiratory Columbus study showing a significant decrease in the exacerbation rate in those patients receiving azithromycin. We have data for roflumilast reducing exacerbations in these patients, but no data in mortality for these two interventions. And the last study that was also a bit of a deception was the SUMMIT study that hasn't been published yet. We have only communication about the results. This included more than 16,000 patients with COPD 2 or less, with cardiovascular risk factors or cardiovascular disease. And the hypothesis here was that ICS could decrease mortality in this subpopulation of patients. This was based on a post-hoc analysis results suggesting a decrease in mortality by 30%. And unfortunately here, there was no benefit of the combined therapy ICS-LABA versus placebo to decrease mortality. And I think this is really the proof that we really need to do the study and not to base our recommendations on post-hoc analysis of other studies. So are there other ways to prolong survival in this population? I think the answer is yes. And probably the most important factor to look at is comorbidities. This is the so-called fancy comorbidome, in which comorbidities with a prevalence over 10% are represented. So we see that most of our patients do have arterial hypertension, coronary artery disease, hyperlipidemia, and many other comorbidities, and they might play a bigger role in the survival as compared to the COPD itself. We also know that with the increased number of comorbidities, there is an increase in the probability of dying, no matter which COPD GOLD class you are in, according to your airflow limitation. So it's relevant from COPD GOLD 1 to GOLD 4. And there are several ways of trying to classify patients according to their risk. This is an approach that uses phenotyping in COPD and classified patients in 3 different groups and try to find out whether there are differences between these groups. It could identify that in the group 1, patients with lower FEV1s, they had an increased hospitalization and increased morbidity and mortality as compared to the group 3 with a more preserved FEV1, but a higher number of comorbidities that had more hospitalizations for cardiovascular reasons. There is also some French efforts in looking at that. In this study, classifying the patients according to 4 different phenotypes and plotting their survival over time. So there is a way to try to put together categories or characteristics of these patients to try to look at more detail at what we have to do to improve their survival. A growing interest has been also being developed to use biomarkers to try to categorize these patients. Proadrenomedulin has been shown several years ago to be associated with the prognosis of acute exacerbation, even adjusted for many other variables in these patients, but also these biomarkers seem to be associated with the overall performance. So there is that data suggesting that both pro-ANP, which is a cardiac biomarker, and pro-ADM are related to physical activity in COPD in the different categories according to the GOLD classification. And we know that if you add a biomarker, in this case, adrenomedulin, you can refine the Bode index in its prediction power for mortality. So if you look at the Bode index, you can dichotomize patients with a higher probability to survive from those with a higher mortality. And the same happens if you use a blood biomarker. Which means that you just have to do one determination in blood and don't have to have the patient walking for the 6-minute walking test, which tend to be difficult to perform, especially in the GP office. We've also seen that the prediction of ability of the body can be improved by 1/4 by adding biomarkers to this index. And at the end, you can differentiate the patients or can categorize patients in one of those 4 categories. So we have a category with very low mortality and a category with a mortality around 20% at 2 years by combining the body results and proadrenomedulin levels. It could be that we will need more than one biomarker to find out which patients are more prone to die at the course of the disease. And in this approach, we have combined proadrenomedulin, pro-ANP, and pro-AVP, and looked at the mortality over time in the group of patients without any increase of biomarkers, in which one biomarker was increased, 2 biomarkers were increased, or all 3 cardiovascular biomarkers were increased. And as you see here, the mortality was really high in patients with an increase of 2 or 3 biomarkers, suggesting that also the cardiovascular risk is really important in COPD, and that these patients might deserve special attention and therapy to avoid mortality. In summary, patients suffering from recurrent exacerbations, particularly those requiring hospital admissions, are prone to have a compromised survival in COPD. There are several interventions that can reduce exacerbation rate, but only some of them proved effective in decreasing mortality in COPD. And this may be due to the fact that most patients die with COPD due to something else, such as cardiovascular disease, and that it might make sense to identify patients at increased risk by using a phenotyping tool or biomarkers in which associated comorbidities should be particularly cared for and treated. And with that, I would like to thank you for your attention, and I'm happy to answer any questions. Thank you.
Thank you, Diana, for your excellent talk. Any questions, please, from the audience? Yes, please.
Congratulations for the presentation. After 3 days of Congress, we hear that almost every combination of LABA and LAMA improves lung infiltration. For first time, we heard from you that does not improve mortality. That's really a very good point. But also you said that pharmacotherapy reduces exacerbations. The question is, if exacerbations augment and deteriorate the mortality, and if pharmacotherapy improves the exacerbation, why does not improve the mortality?
Yeah, well, I think that's a good question. So the question is, if the pharmacotherapy decreases the exacerbation and this exacerbation is linked to mortality, why we cannot prove there's direct relation between treatment and decrease in mortality? I think probably because the effect might be rather small in mortality, and because the other comorbidities, particularly cardiovascular morbidity, can have a greater impact in mortality than COPD itself. I think we have to be aware that in most studies, the adjudication of the cause of death is really difficult, and I think that's what we see in the hospital as well. If somebody dies, we have only a few cases of people really dying in respiratory failure. Most commonly, the patient is dead in bed, then you have to say what was the cause of mortality, and it could have been a heart attack, a pulmonary embolism, or would you say it's a COPD exacerbation? So it's I think, a very difficult line to adjudicate which is really the cause of death, and probably the effect of the comorbidities in the mortality is higher than the COPD itself.
Thank you. I think that now we will learn more.
Okay. Dr. Michailidis, please.
My question is, what do you think about the reduced reservation we have in recent years to use cardioselective beta blockers than we had before as a contributor to the reduction in mortality in COPD exacerbations?
Yeah, I think that's also a very good question. I think there's increasing data suggesting that the underuse of beta blockers in COPD might be related to an increase in mortality, and that we should really think about using beta blockers in all patients with an indication, irrespective whether they have COPD or not, particularly because the risk of dying with cardiovascular disease is much more increased in these patients.
Thank you.
And Dr. Kosmas, please.
Thank you, Diana, for your presentation. I would like to address this topic. I mean, during an exacerbation, there is an acute deterioration of cardiovascular risk factors. I believe what you said about cardiovascular comorbidities is the reason. And in patients with frequent exacerbation, this is somewhat of persistence in systemic inflammation, which leads to chronic modification of cardiovascular risk factors like hypertension, lipids, and all others. I like your opinion in my question, which is, we know that we have a lot of medications that reduce exacerbation. This is without doubt. But the gap is that we do not have studies and data that these medications alter or modify cardiovascular risk factors, which in the long run are going to increase mortality. What do you think?
Yeah, I think that's absolutely right. There is an increasing knowledge relating cardiovascular events with an acute severe exacerbation. There is also data suggesting that there's an increased risk to die from myocardial infarction if you have a pneumonia. That's also been shown that you have sometimes bacteria infecting the myocardial, even in small, very microscopic changes that might lead to electrophysiologic deregulations and sudden death. It's in the acute setting, I think we are learning more and more about that. And I think, again, you are absolutely right that we probably would achieve a greater reduction in mortality by taking more care of the cardiovascular diseases than COPD itself, because, again, most patients die with COPD due to cardiovascular diseases.
So I will finish with one more question. Apart from the randomized clinical trials that you have already mentioned, considering our daily clinical practice, do you believe in the last decade that we have a positive reaction in the term of mortality of COPD?
I think so. Absolutely, I think so, and I think perhaps it's not only due to the acute treatment of the exacerbation, because this has not changed over the last years. We perhaps have learned that we don't need to give steroids for 10 days or 14 days or 2 weeks, that 5 days oral steroids are enough to treat the exacerbation. But I think the whole care that we devote to the stable patient is improving mortality. So we look at smoking cessation, we look at vaccinations, we look at reducing exacerbations. I think everything else, rehabilitation we do for these patients, decrease mortality. Again, I think mortality is an important endpoint, and it's an objective endpoint. But I also think that for most COPD patients, life quality and exercise capacity is at least as important as survival. So probably if you could give the patient the chance, you live 20 years with a very poor quality of life, or you live 15 years with a very good quality of life, I'm not sure how people would decide. And that's the reason why I think we should also focus on quality of life, on exercise capacity. So mortality is important, but the other parameters and the other outcomes are as important as survival.
So we'd like to thank you for being here in Athens,
Thank you.
for your contribution to our Congress.